Minister Ong Ye Kung. Mr. Gerald Giam, I think I'll take clarifications at the end of the debate, please.
Thank you. The speech is slightly long. Mr. Deputy Speaker, sir, I thank the members for all your questions and my MOH colleagues for answering the bulk of them. In closing, I will address the few remaining issues, and then I will take a step back and share a broader perspective of the challenge that we are facing concerning healthcare. Let me start with TCM. It's raised by several members, Leader of the Opposition, Mr. Yip Hom Wing, Ms. Henny So, Ms. Joan Pereira. But maybe I start with, we seem to have this mood here where we talk about who made what speeches in the past. Let me give my version. I came into MOH about 1.5 years ago, and what struck me was the tremendous amount of groundwork that was done by my predecessor in laying a preventive health infrastructure, the IT system, the 3 clusters, and all the medical protocols. And so I walked into a work plan seminar. As the new health minister, I have to speak to all senior doctors and management at a work plan seminar. Very daunting. So I discussed with 3 very learned persons, that our 3 DMSs, the Director of Medical Services, Professor Kenneth Mark, Professor Benjamin Ong, and then Professor Tan Chaw Chuan. I had in-depth discussion with them to discuss what's the next phase of healthcare. And I think we zoom in on preventive care. And the good thing is so much groundwork has been laid. And so May 23rd, I think, 2021, I made my first speech in MOH. We talked about 2 topics. One was COVID-19, living with COVID, and second was preventive care. That was when Healthier SG was first talked about. But really thanks to several ministers before me and the whole team who laid so much groundwork. Then we had COVID closures and all that. We didn't have many events until December. Now that thanks to Mr. Pritam Singh for reminding me, December I got invited, finally, an event by the TCM community, and that's why I spoke to them with the indication that if we focus on preventive care, I think it's an impetus that we can make a breakthrough and feature TCM in preventive care. And that was how the thinking first started. And my last 2 speeches about TCM, I made quite a few TCM speeches. They're all in Chinese. The coverage has been uneven, So it's good that I have this opportunity now to explain it in English. And the 2 speeches I last made was quite recent. Mr. Patrick Tay was there in one of the events in September last month. In summary, this was what I have been telling the TCM community and what we have been doing. Number 1, MOH has always recognized the tremendous value of TCM and the benefits they have brought to the community. I specifically always mentioned during COVID-19, and the Leader of Opposition mentioned this as well, during COVID-19, I personally wrote to our TCM clinicians to say, please advise your patients to take the vaccines. And I think they were a great help and really helped us move the needle in getting heartlanders to take the vaccine. But I've also explained we must recognize that Western medicine and TCM, they evolve very differently throughout history. They are 2 separate systems, complete systems, with their own discipline and their own know-how. They may intersect at some point, they may overlap, but you cannot make one to be like the other. It's not possible. They are 2 complete holistic systems. So you take, for example, you ask a Western doctor, how do you balance the 5 elements of a human body to keep him healthy? Most Western doctors will profess they wouldn't know. We are doctors in the house. I don't think you will profess that you know. And you ask a TCM doctor, this patient needs a life-saving urgent operation. Can you replace it with herbal medication? They will say no, go for the operation. Most TCM practitioners I know will say that too. So I think they respect each other's space, their strengths, and their discipline. And when it comes to regulation, there's a fundamental difference as well. Western medicine is a lot about research, clinical evidence, efficacy, safety, and when you get the data, the drug, the treatment can be approved. It's tightly regulated and by law. TCM is passed down from generations. Great-great-great-great-grandfather took that, passed down to great-great-grandfather, and just culturally, traditionally, they trust that herbal medicine. And you ask for clinical evidence, don't have, right? You want to go for MediSafe, today's rules, it must be a medicine, must be certified by HSA with clinical data. TCM, that's hard to come by. Yeah. What TCM is very strong in is preventive care. Even more than 2,000 years ago, there's already this saying, 养生三法，饮食有节，起居有常，不忘坐牢. Very hard to translate, but let me try. Even the literal translation doesn't capture the full meaning. It means there are 3 aspects to health. You eat, not just in moderation, actually, 饮食有节 is you eat what your body requires. Go according to the seasons. 起居有常 means you have a healthy daily routine that follows the rhythm of the day, the month and the year probably, and not to over-assert your body, heart, and your mind. So in the area of preventive care, that's where I think Western medicine and TCM share a common understanding. You'll notice in my opening speech, I have a symmetry where I talk about preventive care and how the other side also have been emphasizing on it. And both sides, both disciplines believe that early management of risk factors and disease can stave off problems and complications later on in life. And therefore, I believe when we focus on preventive care under Healthier SG, we hope TCM can play a role. While we work that out, in the meantime, we encourage TCM practitioners continue to do what you're good at, advise the patients to take care of their health, pick up good habits, live healthily, and take care of their health holistically. But as I said in my parliamentary reply, TCM is self-regulated with varying standards of practice. So over the last year, MOH and the TCM community, we have established 2 work groups. They work on issues such as enhancing TCM clinical training, improving career development, and once completed, this can be a basis to explore how to involve TCM in support of Healthier SG. But I do not think, as one member suggested, I do not think we should impose the regulation of Western medicine on TCM. I think self-regulation for something that is traditional and cultural would be more appropriate. But we need to strengthen that self-regulation. We have also recently finalized the succession plan of the chairman of the TCM board. This is our partner, MOH's partner in the TCM community. Ms. Yu Fu Yisun has been chairman for, I think, 3 terms or more, a lot of contributions. The incoming chairman will be Dr. Teo Ho Pin. It's another familiar colleague of ours. He has taken up the chairmanship with gusto. I've had several discussions with him. He understands the shoes he has to fill, the big shoes he has to fill, MOH's position and thinking, especially in the context of Healthier SG, and I think he understands his task as the TCM board chairman. Once we can feature TCM in Healthier SG, then the suggestions that the Leader of Opposition has put forth, I think, will be considered. And there will be a certain natural forward movement in our policy thinking. Yeah. I just said one last thing before I move to another topic. Is Mr. Pritam Singh mentioned psyllium and fibogel. I think it's the same thing. It's not that one is Western medicine, one is TCM, one is funded, one is not. If I'm not wrong, there's doctors in the house, please correct me. I think it's the same thing. Psyllium is the seed for fiber supplement. Fibogel is essentially psyllium with a brand called Fibogel. Both are not medicine, both are dietary supplement, fiber supplement. But like all things sold in the polyclinic, including the gauze you use to dress your wound, they will all be subsidized, including including not drugs, but supplement. Yeah. But there are doctors in the house. Please correct me if I'm not wrong. If I'm wrong. Yeah. Let me move to the next topic. crowded GPs raised by several members. Dr. Tan Wu Ming, Mr. Yip Hong Wing, Mr. Ang Wei Neng all expressed concerns that if GPs become very popular, residents can get squeezed out by the huge demand. I tried to explain some of this in my opening speech, and that we will try our best to manage this. We will ask GPs to set a limit on the number of residents they can enroll. How many will depend on the clinic and the doctor's own judgment, how many more can he take? Yeah, so it will differ from clinic to clinic. We are also implementing enrollment in phases. We will prompt residents to enroll with their usual GPs, the drop-down list. Your most frequented GP will be first, and we'll encourage residents to enroll early and not wait. I take comfort that we are discussing this because we are worried the demand will be overwhelming. It's in a way a good problem. It's better than the feedback coming back is we think nobody will enroll, and that will be a bigger problem. But if GPs are to over time accept enrollment from the entire population and help keep them healthy, they got to shift out of some of their current load. And I'm glad a couple of members have given a good suggestion. Mr. Melvin Yong suggested for employers not to insist on workers producing MCs whenever they are sick. Many common ailments, cough, cold, they can be managed with more rest, drink more water, perhaps some off-the-shelf, off-the-counter medication, including TCM medication. Yeah. Ironically, the disease where this is most practiced now is COVID-19. But if we insist we want to see a GP, we queue up and see the family doctor in order to get an MC. Today, a lot of people practice that, but actually it's not the best use of a doctor's precious time and resources. Many employers already do not insist on MCs for COVID-19. Mr. Melvin Yong mentioned our healthcare clusters today accept up to 3 days of sick leave without the need to produce an MC. The civil service grants officers up to 2 for mild conditions like cough and cold. And I hope this can become a prevalent practice. Now let me talk about drug prices. Mr. Gerald Giam asked a series of questions about our effort to substantively remove difference in drug prices between GP clinics and polyclinics for residents enrolled in Healthier SG. As I said in my opening speech, the basis of subsidy for polyclinics and for charge in GP clinics are different. The former, which is polyclinic, takes into account of age. But for charge in GP clinics, a major factor for consideration is income. So we can't remove the differences up to the last cent. And for the higher income households, the difference may well remain in dollars. But parity of drug prices is an important concern, told to us by many residents when we did our consultation, and we'll try our best to make sure there is drug price parity, especially for the lower income. Now, let me move on to the next subject, which is delivering outcomes and KPIs. A number of members talk about KPIs and outcomes, and there was an exchange between Mr. Gerald Giam and Ms. Mariam Jaafar yesterday. Of course, we have to measure outcomes and set targets. That is why we listed short, medium, long-term KPIs in the white paper. The work has just begun. Healthier SG is a dynamic, multi-year transformation exercise. There will be twists, turns, and uncertainties along the way. MOH is having extensive discussions with clinicians and other stakeholders to set out the technical definitions and our approach to data sharing and measuring these outcomes. And from there, we will establish the baselines of various indicators and then determine what targets we want to achieve and by when. While it is important to measure outcomes and targets, those who have run organizations before will know that this is not straightforward. I used to be involved in workers' training, so I interacted a lot with HR practitioners. And HR practitioners always lament, and this is not just for Singapore, it's the whole world. They always lament employees are overmanaged but under-led. Overmanaged, under-led. The unions always say that. Because if you're a manager and you're in the middle of a big change management exercise, you will likely instinctively say, what are the targets? Let's measure the target. Whatever measured, get done, right? That's what the manager always say. Ms. Hazel Phua went further to say, let's measure the targets achieved by the GPs. And if they don't achieve, claw back the service fee. But as Dr. Tanya Swam cautioned, it is important for GPs and MOH to work together and for GPs to feel that they are integral part of this change. And I agree with Dr. Tan. Ms. Mariam Jaafar, my colleague from Sembawang and an experienced management consultant, immediately she raised a red flag. I think she has seen enough organizational changes to notice the danger of blindly chasing KPIs and targets. Because I talk about what the manager will do. What will a leader do? A leader that is driving the change will have a different starting point. He or she, the starting point is bring everyone on board, make sure everyone understands and buys into the mission and objective. Then we jointly set KPIs and targets and then do our best to achieve them in the right spirit. If we don't do that, then we are not leading. We are only managing. And if in our zeal to overmanage, we penalize people for not meeting targets in the middle of a big change, that's when people become cynical and they lose heart. And then you get perverse outcomes like what Dr. Lim Wee Kiat said. Imagine if we really say, doctors, you don't meet your KPI, we claw back your service fee, then it's very simple for the doctors. Number one, either I don't join Healthier SG, or two, I join, but I cherry pick the healthy residents. Yeah. So the way we look at KPIs, always you are able to differentiate the leaders from the managers. Since we are on the topic of outcomes, I want to respond to Ms. Mariam Jaafar. She's not here today. She has to fly off for work. But she had a very thoughtful and insightful explanation of value-based care. And I think it's worth responding to her. She cited several good international practices. I want to assure the House that our hospitals have already been implementing value-based healthcare through many such initiatives too. We just did not feature them in the white paper under Healthier SG. So one example, there are many examples. One are all the community measures taken to help resuscitate out-of-hospital cardiac arrests by making defibrillators available in the community, training members of the public to perform CPR, alerting them through apps that there is a cardiac arrest nearby. And so far, the survival rate of out-of-hospital cardiac arrest has improved by 10 times, 2% to 22% over the past few years, over the years. Changi General Hospital has set up a post-acute myocardial infarction clinic to support patients in their post-heart surgery recovery. The idea is to review the patient's condition early, within 2 weeks. And this has resulted in a reduction of 30-day readmission rate from 14.3% to 9.6%. There are many such examples, and I hope Ms. Mariam Jaafar and the House will be comforted that our clinicians are always thinking of better ways to deliver better clinical outcomes. Let me now comment about capitation. A few members have raised the issue of capitation. I agree with members on the benefits of capitation funding, but we are doing it step by step and carefully. I explained how we are doing it at the GP level during my opening speech by extending them a standard base fee per enrolled resident. So it's loosely a capitation payment. At the healthcare cluster level, we have changed the basis of calculating their budgets to be capitation-based. They still get the same budget, except the basis of calculation have moved away from based on workload to capitation, the population that they are taking care of. So they receive fixed capitated budgets for residents of different age bands. So for very young, they have to do a lot more work, have higher capitation rate. As people get older and young adults will have the lowest capitation rates, and as you get older and you need to pay more attention to their healthcare, capitation rate goes up again. And so age bands, that's a reasonable proxy for both workload as well as health risk. Ms. Sylvia Lin asked whether we can publish the rate. For now, I think it's better we keep this as internal parameters within MOH. In any case, the annual reports and financial statements of the clusters, they are available if you get them from ACRA. Clusters, they have in turn cascaded down, or they will cascade down, healthier SG KPIs to all their institutions and departments. But they will not yet capitate the budgets of hospitals, polyclinics, or community hospitals. So below the clusters, institutions, healthcare institutions will still be funded the same way for now. But capitation funding is a direction we want to move towards. It is a big change, and we will have to study and plan each move carefully, making sure every institution, every partner is ready before we do so. When it happens, it must be accompanied by a significant granting of autonomy so that healthcare institutions, they can make the right siting decisions properly. I give you an example, a palliative care, a hospice, for example. Today, we fund them through workload, same formula, but we can capitate their budget. So a palliative care provider, they can receive a standard base fee for each palliative patient they take care of. And then they decide which services are in the best interest of each patient, whether they should go to inpatient hospice care, home care, or day care. And they don't have to worry about separate funding for separate services under separate settings. So that's where we have a lot of potential. Now let me move to a next important topic, which is manpower. Several members, Dr. Tan Wu Ming, Dr. Tan Ya Swam, Ms. Mariam Jaffa, Mr. Dennis Tan, Ms. He Ting Ru, they raised concerns about manpower, and I appreciate that. It is a major challenge. The key challenge is to have sufficient nurses, allied health professionals, support care staff to operate hospitals, clinics, also elder care centers. These few groups number about 58,000 now, and MOH estimates that this will need to grow to 82,000 in 2030, 58,000 to 82,000 from now to 2030. We will broaden training for our healthcare workers, nurses, allied health professionals, pharmacists, so that they can take on the crucial roles alongside doctors in preventive care. For example, nurses in the community will be trained in lifestyle coaching to empower residents to take good choices according to their care needs. Undergraduate allied health courses comprise specific modules on population health, health promotion, chronic disease management. Mr. Mark Che suggested some useful training for doctors about physical fitness, and I think we will follow up discussion with him on how we can improve or broaden the range of courses that doctors can go to for their continuous training. Our community pharmacists are now able to provide smoking cessation and weight management services, and there are plans to train them in influenza vaccination. But first, there must be enough people to train. There's, again, a certain narrative going around. Some members alluded to this narrative, that hospital staff are leaving because they are overworked. Attrition rate is at record high. People are avoiding the healthcare sector, and then we must do campaigns, reduce workload, raise salaries to attract more people. That's the common narrative now going around. There are some elements of truth in this narrative, such as there is indeed a manpower crunch, and hospital staff have been working very hard, especially during the pandemic. But the rest is less than fully factual. They propagate some negative energy and may not help us tackle the actual problems. You take the attractiveness of the healthcare sector. Are young people really avoiding the sector? 10 years ago, IT, polytechnics, and universities in Singapore took in about 1,500 nursing students a year, 1,005. Now this has gone up to 2,001, and we are trying to increase it further to 2,003 in the next couple of years. Our education institutions, they receive many more applications than there are places. At this number, we are attracting 4% of student cohort into nursing. And if we maintain that number while cohort sizes shrink, that percentage will drift up to maybe 5% of each cohort. That means for every 20 local students you see in a class, one will be trained to become a nurse, and they are applying. So healthcare have a very fair share of the local talent pool, considering that there are so many sectors vying for local talent. Or on attrition rate, is it really at record high? If we look at local nurses, normal annual attrition rate every year is about 6.4%, which is not high by any industry standard. In 2020, when the pandemic struck, it went down. It went down to 5.4%, because many of our nurses who were planning to retire or resign in the face of the pandemic decided to stay and fight. In 2021, there was a slight rebound to 7.4%. In 2022, this year, so far, the numbers have reverted to that of normal years. There was no mass exodus of local nurses. These are the numbers. Nurses have remained dedicated and steadfast and bravely stood their ground in the face of the pandemic. But what has gone up is the attrition of foreign nurses, from about 8.9% in normal years to 14.8% in 2021. This is where there is record high attrition, at least over the past few years. We know the main reason, and Dr. Tan Ya Swam talked about it, which is that the pandemic has increased the demand for nurses all over the world. And our foreign nurses are being poached by other countries. So they go to New Zealand, Australia, the UK, UAE. So if we want to tackle the manpower crunch in healthcare, the starting point is to hold on to our foreign nurses in the face of heightened international competition. Only then can we reduce the workload for all nurses, which many members have called for. But we must be clear, where is our starting point? Remember, healthcare is one sector that is directly affected by our demographic changes. An expanding aged population needs more healthcare and more healthcare manpower. A shrinking young population limits the number of new local talent that we can bring into healthcare. And therefore, if we are honest with ourselves, we know the numbers simply will not add up if we just rely on local nurses or local manpower, no matter how hard we try to expand the local pipeline. And therefore, if we want to take care of our seniors and the sick, if we want to reduce the workload of healthcare workers, or at least make it more manageable, we must expect foreign healthcare workers to play a bigger role in the coming years. And this is especially so for areas where there is a more severe manpower crunch, such as aged care or palliative care. The great majority of our nursing workforce will still be locals, but the number and the role of foreign nurses will need to grow. MOH is therefore securing various pipelines of good foreign healthcare workers from different source countries to bring them here and further train and develop them. Some may leave us after a few years, but we will try to keep the majority, especially those who have become an integral part of our care teams. Dr. Tan Ya Swam suggested granting the good performance PR. and MOH is supportive of this. ICA, they always assess PR applications holistically, including taking into account their economic and social contribution of the applicants. So when it comes to evaluating applications from foreign healthcare workers, ICA will certainly consider the important contributions of healthcare workers and the MOH's support for the applicants. At this juncture, Mr. Deputy Speaker, I would like to say a few words to our healthcare workers through you. I believe the great majority of Singaporeans respect and appreciate our healthcare workers. We have seen the outpouring of public support in recent past for sacrifices made by frontliners as they steadfastly battled the COVID-19 pandemic. However, many of our healthcare workers have also experienced abuse by patients and family members who lashed out at them because hospital and clinics are high-stress environments. I hope that our healthcare workers will look past a small minority that show disrespect and have faith that the great majority salute you, which includes everyone in MOH. And I believe I speak for everyone, every member of this House, that we too respect them and their work, whether they are men or women, young or old, locals or foreigners. Abuse against healthcare workers cannot and should not go unaddressed. We hope to raise public awareness on abusive behavior. That should be stopped and equip healthcare workers to better handle such situations. Mr. Deputy Speaker, sir, ultimately, we need to squarely tackle the challenge before us, which is our society is aging fast. It is a worldwide trend. By 2030, the old will outnumber the young in the world, the first time in recorded human history. East Asia, in particular, is aging faster than any other region in the world due to declining fertility and people living longer lives. And within East Asia, the countries aging the fastest are Japan, South Korea, and Singapore. We are called the advanced agers. Members have heard this statistic many times. By 2030, 1 in 4 Singaporeans, thereabouts, will be 65 and above, up from 1 in 6 today. But it's not just a statistic. The number translates into real impact on our lives, and we have yet to feel the full brunt of it. Say, companies, you will face a shortage of workers, requiring you to move into automation, adopt less manpower-intensive business models while using foreign workers judiciously. For schools, shrinking student intake, which is why MOE have to merge schools, and some of us find our alma maters gone. Within communities, we have to make sure estates are now barrier-free. Traffic light junction, the green man will have to appear longer because people take longer to cross the road. If you are a driver, you will have to slow down in the HDB estate. And we already have silver zones. For families, more and more couples will find that they have to take care of 2 sets of aged parents in addition to their own children. In the healthcare sector, we see rising disease burden, escalating demands for hospitals, clinics, doctors, nurses, budget, etc. Most importantly, the seniors themselves, as they see more of them, they'll be asking, how do I live purposefully and healthily with dignity in my old age? Mr. Henry Kwek, Ms. Ting Pei Ling, Ms. Cheng Li Hui, Ms. Carrie Tan raised these concerns. And importantly, they warn us of the danger of isolation of seniors and the importance of social contacts for seniors. Aging is a major topic. The impact spans across various sectors. Today, let me just address the implication on healthcare. Our basic premise must be this. Aging may be an inexorable trend, but the rapid escalation of disease burden and suffering need not be a given. We can manage this, provided we stay healthy. Many of us, myself included, we are guilty for being caught in the old mold where life stages are determined by age. 5 years old, go preschool, 12 years old, take PSLE, 20 plus, graduate. By then, roughly, you should find boyfriend, girlfriend, apply BTO. Late 20s, get married. 50s, beware of onset of chronic illness. 60 plus, retire. Beyond 80, you may start to become frail. The age markers remain relevant and can continue to guide us in understanding life stages, key events, risks throughout our lives. But we need not be straitjacketed by them, especially when it comes to health and aging. You take, for example, there's no reason why 50s has to be the onset of chronic illnesses. We can stay healthy and not have chronic illnesses in our 50s. There's no reason why once you cross 65, you go into the wrong side of the dependency ratio. There's also no reason that why 80s must be associated with frailty. We can delay it as long as you can, well into your 80s or 90s. Policy planners will continue to monitor the statistics based on age, but as individuals, we can choose to differ from these widely accepted assumptions. And the government can make policy changes and reform our systems to help individuals achieve that. To do so, we need to recognize now that the healthcare system is not one system. It's not just one system, but 3 interconnected systems, working together to deliver good outcomes. The first system is the acute care system. This is what typically comes to mind when we think of the healthcare system. It comprises hospitals, specialist clinics, emergency departments, the places that treat us and cure us when we are sick. We are expanding this system, building more acute and community hospitals in the coming years. The second system, less known, is the public health system. One important part of the public health system is the control of infectious diseases. And we can see this system springing to rigorous action during the pandemic. The other important part of the public health system is the one that improves the health of our population. And this comprises policies and processes for preventive care, including the network of family doctors, their long-lasting relationships with residents, the practice of regular health screening, the culture of good lifestyle habits, all of which keep a people healthy. And this is the system that we are now building and strengthening through Healthier SG. We have seen how the two systems complement each other during COVID-19. Public health systems strengthened the surveillance of the virus, got people to adopt good hygiene habits, receive vaccinations, stay home if unwell. The acute care system took care of those who got infected and experienced more severe symptoms. But still, the two systems are not enough. In an aging society like ours, the third system is equally critical, and that is the aged care system. This is the support system for the large segment of people who are advancing in age. And this system is not about nursing homes. The nursing homes, they serve an important purpose, which is to care for seniors who are very frail and unable to live independently, whose families cannot support them. But nursing homes are not and cannot be the mainstream solution to aging. We are building nursing homes very quickly, from 16,200 beds now to 31,000 beds in 2030. I'm sure we need them as our population ages, but the projected pace of expansion is worrying. In our Asian culture, we value caring for our seniors at home. Our seniors also prefer to age in a familiar environment, and we should not lose this. As a society, we must guard against the assumption that seniors will always become sick and frail and unable to take care of themselves. It's quite a risky mindset because it will exacerbate our challenge. Because over time, society will, perhaps unintentionally, push more older people to become isolated, which many members have warned us of. Our instincts backfire from time to time. We would have come across such stories. Let's say a senior went to the market, went marketing in the wet market, and then he fell. The family may, to protect him, tell him, don't go out anymore. We'll hire a domestic helper to watch after you. Or a senior cook forgot to switch off the stove and fortunately discovered early. Family may tell her, don't cook anymore. We order in for you every meal. We might do all this out of concern for our loved ones, but in doing so, we deprive them of physical activity, a sense of agency, a sense of dignity. We want to protect them, but we unintentionally expose them to an even greater risk of isolation and loneliness. That is where the spirit wears out, the body gives way. If that mindset becomes entrenched, then over time, seniors become a problem to be contained, put aside in nursing home, out of sight, out of mind. It's like a room in the house where you put all your problems and you don't want to see. One day, that room will burst. We must support as many seniors as possible to continue to live in community, independently or with some help, contributing to the best of their ability, able to choose their own activities, having a full social life with friends and family. I visited Block 115 that Mr. Henry Quek talked about. It's not run on a big budget. A lot of passionate volunteers. We all know who got involved, but it's doing such heavy lifting and making such a huge difference to the seniors living in that block. And I came across this piece of research, which estimated that the health impact of loneliness of a senior is equivalent to smoking 15 cigarettes a day. We estimate that today, 97% of our seniors above 65, they can either live independently or with some help in the community. We must maintain or improve that share and not inadvertently give them the equivalent of 15 cigarettes a day and weaken their health and ability to live independently. For the large majority of seniors, what they need most is social care, more than health care. And the way to deliver that is to enable aging in communities. And we will need a range of solutions to anchor aging in communities. This includes building more community care apartments that Second Minister Masagos talked about, and releasing land for private assisted living facilities. But the greatest asset for managing aging is actually right before us, and that is our HDB estates. Most estates already have ample shared spaces for interaction and activities. You got your void deck, your coffee shop, your supermarket, your RC center, our elder care center, your community clubs. We did not specifically build them as infrastructure to support aging, but they are extremely valuable in our aging society. And that is why MOH, we are rapidly expanding our network of elder care centers to activate these existing spaces and create more shared spaces and social networks for seniors. And we are working closely with AIC to provide training opportunities for our centers to take on an expanded role under Healthier SG. As a social worker told me, a very effective initiative is to simply bring the seniors to that shared space to cook and enjoy a meal. And once they eat together, they socialize, they start doing different kinds of activities together. And there's no risk of forgetting to switch off your stove. And we will definitely improve the way Elder Care Center works. As suggested by Ms. Janet Ang, for those who are in their last lap of their health journey, we are expanding palliative care, especially at home, to allow our loved ones to pass on as comfortably and with as much dignity as possible. This is the wish of most seniors, and we should try our best to fulfill it. Aging in communities will be the next major area of change and reform in healthcare that we need to work on. When all three systems, acute care system, public health system, aged care system, they work together synergistically, healthcare happens everywhere, and not just in medical facilities. So I thank Dr. Tan Wu Ming for for sharing the story of Ama and pointing out that healthcare subsidies should not be tied to services being delivered in brick-and-mortar facilities. This will naturally have to be reviewed as we shift our paradigm. Mr. Deputy Speaker, sir, let me conclude. Some countries may place a stronger emphasis on just one of the three systems or organize them in a way that they end up working in silo. For example, Japan, as a super-aging society, has a great focus on aged and institutional care. The US acute care system is state-driven, but public health is driven at the federal level. In Singapore, we take an integrated approach. Acute care, public health, aged care, all come under MOH. The Minister for Health is also the Minister in charge of aging issues and chairs a multi-ministry task force going beyond healthcare. And this is an important advantage for us. MOH is in a position to develop a cogent and comprehensive plan, master resources to transform and fire up all three systems to deliver health outcomes for our people. Healthier SG is a key effort to activate and reform the public health system, empower individuals to choose health, and lay the foundation for the aged care system I spoke about. And we need all stakeholders, doctors, community partners, healthcare clusters, employers, residents, to join us in this effort to shape a healthier Singapore. And we do this for ourselves, we do this for each other. All societies at some point will have to confront population aging. It is an urgent and stern test, and some societies end up with bankrupted healthcare system or let healthcare cripple their society and economy. We are determined to overcome this test. We have the resources, ability, organization, and determination to do this. I seek the support of this House and of the people of Singapore to endorse this Healthier SG effort as the basis to transform our healthcare system so as to strive towards the vision of long and healthy lives for Singaporeans. Thank you, Deputy Speaker.
We have had a healthy debate over 2 days. Members deserve a chance to seek clarifications. This will also allow MOH's, POHs to further explain MOH's priorities. In the interest of time, members are invited to ask short clarifications, please. Dr. Tan Wu Meng.
Mr. Deputy Speaker, I thank the Minister for Health for his support and statement supporting our healthcare workers across Singapore who continue keeping Singapore's patients safe and looked after even as the COVID pandemic winds down and the BAU load continues apace. I also want to thank Minister for recognizing the challenge that my Clementi resident, Ama, went through. The family had asked me to tell her story, and I'm glad that the difficulties she went through and her family went through have been recognized and will be looked at by MOH. I have a clarification to ask about how we support residents and patients who are in the frail stage of their health. These are residents who may have a number of medical conditions, who are not quite so ill that they may need to be admitted or have to go to a care home, but not quite in the pink of health. And they often have many medical conditions with many follow-ups. In a PQ earlier this year that I asked and which I raised in COS, there are Singaporeans today who may have 20 or even 30 outpatient visits in a single year. Each of these visits poses challenges for the caregivers, especially caregivers who may be daily rated, can't get time off from their employer. As part of Healthier SG and strengthening coordination of care, can the ministry also help look at ways to reduce the number of visits by giving care providers, doctors, healthcare workers additional time and bandwidth to help further coordinate and streamline the care for such patients who face frailty and many medical issues. Thank you.
Minister Ong.
Thank you. We'll try our best to streamline the procedures, but without belabeling what I just said in my closing speech. Frailty, we may see it as a permanent condition, but they can improve. And if you ask Mr. Henry Quek in his blog 115, people have improved. They saw seniors who couldn't walk. You bring them, you create that space, common space in that block. First step, make sure they stick to their medication. Take their medication, gradually they improve. Then give them better food, social connections with nutrition and confidence, interacting with people, they actually become better, even though they are in their 80s. I think Mr. Henry Quek can tell more of that story, but we see it can happen. We see in Kampong Wellness, doing that Ms. Carrie Tan spoke about, also a similar effort, a different shape, but similar effort. So without belaboring the point, I think there's a lot of potential we can do for the current generation of aging in communities, social care, including healthcare, can improve their health and push back frailty as long as possible. For a younger group, healthier SG. Postpone frailty as long as we can. Make sure our healthy life is as long as our biological life.
Mr. Pritam Singh.
Thank you, Mr. Deputy Speaker. Just a minor point to clarify the query Minister raised about the particular product I was referring to, psyllium husk. So I think Minister will understand why I had some trouble trying to identify the name it is marketed under, because the box says telephone brand Sat Isabgol psyllium husk. And so this product is produced in Gujarat, and it's, as the Minister said, substantively the same product as Fibogel. And Fibogel, as we know, is commonly prescribed, especially after invasive surgical procedures where individuals may suffer from constipation. And I think the point I was making really is in parallel with the point Minister made about the intersection between Western medicine and alternative medicine. And if we can extract savings from that intersection, I think this will be consistent with watching the fiscal numbers on healthcare going forward. Thank you.
Ms. Ng Ling Ling.
Thank you, Deputy Speaker. I want to thank all the POHs for health for your very, very helpful responses to all the speeches that's been made. And you see that as a member of the GPC for Health, we have all spoken out because it is a really important initiative for the population health of Singapore. I have one clarification for the Minister for Health. I'd like to ask, of the 1 billion startup funds that you mentioned and potentially 400 million recurrent funds to support this whole initiative, how will it be broadly allocated to the stakeholders in this whole ecosystem that needs to make this work, especially for the GPs that we know have to do a lot of the heavy lifting, as well as the residents who have to feel the incentive to take ownership of their health. Thank you.
I don't have the numbers with me, but of the 1 billion, slightly over a billion, there's a chunk for the central IT system. There's a chunk to upgrade the capabilities and IT capabilities of GPs. There's a chunk to upgrade or build up capabilities within the clusters in order to be regional health managers. There's a chunk to one-time ramp up of social activities. And we're also thinking of enrollment. There could be some incentives. So there's another chunk there. So they all add up to over $1 billion. But what you did not ask is also in terms of recurrent. I did mention recurrent expenses of about $400 million a year. That recurrent amount, about half will go to GPs as the service fee, the capitated service fee for looking after enrolled patients. And another half will be the additional subsidies for residents, including health points, health screening, and so on, which will be free. So it's about 50-50 for recurrent. Yeah.
Dr. Tan Ye Swam.
thank you for the opportunity. Mr. Deputy Speaker and the House, I would like to thank Minister Ong for acknowledging the contributions of healthcare workers, especially in the past 2 years. 3 big points. One is that my own term here as an MP is limited and it will come to an end pretty much soon. I hope that all of you will continue to engage with healthcare workers on the ground, not just doctors, to reflect our view. Doctors have always felt that we cannot be a union and sometimes marginalized. And as it is, there are 15,000 doctors in Singapore. There are even more nurses around. And someone needs to help represent healthcare workers as we forge forward for Healthier SG. Final point. Oh dear. Final point. Oh no, I'm so nervous I lost my train of thought. I will email Minister Ong separately about my final point. Thank you.
Well, you have the opportunity to ask it if you can think of it in the next 5 minutes. Oh, okay.
You remember? Okay.
Go ahead.
Okay, I am so sorry. Okay, about the KPIs, one big thing is that as MOH and various committees talk about KPIs, please remember to involve doctors in the conversation and not be chasing economic, which is more economically viable. Let doctors advise you on what we think are reasonable medical and clinical KPIs. Thank you.
Minister Ong.
On the second issue, that is natural. For MOH, we always err on the side of over-consulting, especially our medical experts. On representing healthcare workers in the chamber, I think we have NTUC here, and I think they will always champion workers, and especially nurses and healthcare workers. Yeah, and yeah, we had Dana as NMP before, but even we don't have a healthcare worker as NMP, be rest assured NTUC is there, and the Minister for Health will be here too.
Right. Mr. Gerald Gam.
Thank the Minister and SMS for responding to my proposals and questions. I'd like to seek clarifications from both of them. First, for the Minister, I would like to clarify that KPIs and targets are not synonymous. The white paper already lists many good KPIs. I'm just asking MOH to take the next step to set targets for each KPI so that all stakeholders can work together towards achieving those targets. The best practice in performance management is actually to jointly set KPIs and targets with stakeholders, including doctors, of course, and then review them regularly and make adjustments if the conditions change. So they're not set in stone, but I also don't think that we should start out such a major initiative without any targets set. Secondly, for the SMS, can I clarify with the SMS that under the Healthier SG initiative, residents can choose to enroll with polyclinics instead of with GP clinics? And lastly, the Healthier SG white paper said that MOH will waive the requirement for residents to co-pay part of their bills in cash. Can I clarify that patients will be able to use MediSave to make that co-payment? And will that still be subject to the annual withdrawal limit? Because if this is so, then patients will more likely hit their annual withdrawal limit and thereafter have to co-pay in cash. So even if MOH cannot remove the annual withdrawal limit now, can it consider increasing it to, let's say, $1,000 a year? Thank you.
I'll take the first question, and then SMS Janil will take the next two. Thank you for the clarifications about KPIs and targets. I think we are now essentially on the same page. Thank you.
Thank Mr. Giam for his questions. Yes, they can enroll with polyclinics, and we will continue to review the issue of the annual withdrawal limits. Thank you.
I see last two hands. We'll have Ms. Hazel Phua, and then we'll conclude with Mr. Liang Eng Hua.
Thank you, Deputy Speaker. I just want to make sure that I understood the Minister correctly when he said that there will be no KPI for family doctors and no clawback. And because that would mean that essentially, if I recall correctly, the amount of money that we'll be paying in service fee is $400 million a year. Does that mean that we will be paying this $400 million a year with no accountability?
Ms. Hazelpua asked a question, but she's actually making a statement. She's saying that Healthier SG, 400 million to spend, as I just answered, 400 million is first to subsidize residents for health screening, health points, and all that. The other half is a service fee to GPs to help us take care of population. And I think she just made a statement to say this is not a good spend of money. And if you want it to be spent well, give KPIs and targets to the GPs. And if they do not meet, claw back the fees. This is not what we should do in a major effort like this. We want to bring in the GPs to be part of this. Of course, there will be KPIs with targets, and we collectively work together to achieve it. At the GP level, they will have certain targets as well, but I do not think we want to treat them like vendors and contractors where if you missed out on certain KPI, we claw back the fee. They care about the health of the population as much as we do, maybe more than members in the chamber. Treat them as part of the team. Together in the right spirit, we will look at how well we are doing together by reviewing the targets and adjust along the way to achieve good health for Singaporeans. $1 billion setup, 400 million, if we can keep the population healthy, is money well spent, even though member may think otherwise.
Mr. Liang Eng Hua.
Thank you, Mr. Deputy Speaker. So I'm really happy that the Minister mentioned about the elderly centres to build more in the community, and I agree fully there's a real need for that. The problem is that in many of the estates, like my constituency, Bukit Panjang, we are running out of void deck spaces to build such centres. And many of this, we need to reserve some of the void deck spaces for other activities like funeral, wakes, and so on, which is also a reality of aging. So can I ask the Minister whether will MOH be open to allowing standalone centres, those outside the void decks, which understandably will cost more to build, but there are some spaces that can actually allow such facility to be built. And specifically, my question is whether MOH fund this facility that is outside the void deck centres, which may cost a bit more, but because of the space constraint, we have to do that.
It sounds like a specific Bukit Panjang issue, which we can discuss. We always don't say no right at the outset. Let's look at the circumstances. But the larger point is this. We also tend to look at the problem and then we want to solve the problem. And the first thing is we need real estate. But as I mentioned earlier, if we want to enable aging in communities, look at what assets is already right in front of us. And visiting 115 in Ang Mo Kio is a bit sobering, but it's so inspiring too. They are using their void deck spaces. They took back 4 units, or HDB helped take back 4 units on the second floor. And in that 4 units, there's a medical center, there's a therapy center, there's a place for them to have activities. And so you create the space. And I think, look around our communities, HDB estates are brilliantly built with lots of shared places. We just need to activate them. So while we will look at your proposal, let's not close our minds to also the assets that's already right in front of us.
The question is that this House endorses Paper Command 19 of 2022 on White Paper on Healthier SG as a basis to transform our healthcare system by focusing strongly on preventive care, fostering lasting relationships between residents and family doctors, and building strong partnerships within the community so as to support individuals taking care of their own health and wellness and strive towards our vision of long and healthy lives for Singaporeans. As many as are of that opinion say aye. To the contrary, say no. I think the ayes have it. The ayes have it. Leader of the House.
Mr. Deputy Speaker, I beg to move that at its rising today, Parliament do adjourn to Thursday, 20th October 2022.
The question is that Parliament do adjourn to Thursday, 20th October 2022 As many as are of the opinion say aye.
Aye.
To the contrary, say no. I think the ayes have it. The ayes have it. Leader of the House.
Mr. Deputy Speaker, I beg to move that Parliament do now adjourn.
The question is that Parliament do now adjourn.